Hello, everyone. My name is Hayley McCorkle. Thank you for tuning in to the virtual Nancy and Bill Norton Education Series 30th Anniversary Edition. Now that you all have watched the bacteria in the GI Tract session, we have gathered each one of the presenters here today to have an open panel discussion. And with us, we have presenter Dr. Bill Chey, who is the Timothy T. Nostrand Collegiate Professor of Gastroenterology and Nutrition Science at Michigan Medicine in Ann Arbor, Michigan. He is also the director of the GI Physiology Laboratory, the Digestive Disorders in Nutrition and Behavioral Health Program, and the Michigan Food for Life Kitchen. And he is also the medical director of the Michigan Bowel Control Program. So in his presentation on H. pylori, you all learned about the prevalence of H. pylori, common complications, other indications, diagnostic testing, and treatment options. We also have with us today Dr. Darren Brenner, who is the Associate Professor of the Medicine and Surgery in the Division of Gastroenterology at Northwestern University, and he serves as the Director of the Neurogastromotility, co-director of the Integrated Bowel Dysfunction Program, and also the director of their physiology laboratory. During his presentation, you all learned about small intestinal bacterial overgrowth, also known as SIBO. And in this presentation, he told us a lot about what we don't know, what we believe the doctors know, and what we believe doctors see as overblown or concerning the intestinal overgrowth. And he also touched on some of the diagnostic testing and evidence-based treatment options. Last, but certainly not least, we have with us today patient advocate Tina Aswani Omprakash, who during her presentation, she shared a lot about her patient journey and what it has been like living with SIBO since 2015, as well as some other GI illnesses and that she dealt with since she was a young child. So Tina explained some of these symptoms, which even led to her seeking help from her healthcare providers to test for SIBO, and also just how she manages this condition even today. So I just want to say thank you all so much for joining us today.
Thank you for having us.
Thank you.
Yeah, so I watched all of your presentations, and honestly, I loved them. I enjoyed watching each one of them, and I learned so much. And I felt like a lot of these conditions are not as commonly known as we believe that they should be, but they are really starting to gain a lot of attention in the research space, as well as awareness in the patient community. So I'm really excited to kind of have each one of you guys here today so that we can dig a little bit deeper and maybe answer some of the questions that some of our viewers have had. So starting with you, Dr. Chey, you mentioned during your presentation that there was some resistance in the GI space around the gastritis and peptic ulcer disease being known as infectious diseases. How did that actually help lead to finally getting H. pylori accepted in the medical field?
You know, this whole story about H. pylori and all the trouble that Barry Marshall and Robin Warren had in getting people to believe the association between this bacterial infection and development of inflammation in the stomach, peptic ulcer disease, and stomach cancer even, really is a great example of what's happened over and over and over again in medicine. And that is many different things over time have been considered dogma, have been considered fact. And when they've been proven to be wrong, people have only come along kicking and screaming to a new way of thinking about things. When I think about when I was in training many, many years ago, the dictum in regards to ulcer disease was no acid, no ulcer. Ulcers were thought purely the consequence of excessive acid in the stomach or first part of the small intestine, the duodenum. And in fact, people invested their entire careers in trying to understand how acid is produced and why ulcers are related to acid. So you can imagine that when a young upstart came along, somebody literally right out of their training, and completely upended everything that had been learned and taught for decades, that it wasn't very well received. Can you imagine? You're thinking a certain way, having invested your entire life as an investigator, for example, multiple NIH grants, and then have somebody come and tell you that's in your mind a whippersnapper, um, tell you that you're completely wrong, how you'd react. And I think that's exactly what happened. And so, as we talked about during the lecture, the way Barry Marshall proved it was by drinking a flask containing H. pylori and inducing gastritis, as well as symptoms in himself. There's no more persuasive way that he could have utilized to have made his point.
Yes, absolutely. And honestly, what a way for just someone new in the space to kind of take a risk and jump out there to really find something and discover something that would be so impactful to the field. And even today, we're still talking about it. Um, so that's an extremely touching story. And thank you for even bringing that up during your lecture. So one other question that I think is important kind of for you to touch on again and maybe go into explaining just a little bit more. You talked about it during your presentation, but actually how common is H. pylori today and what other conditions should the community be aware about that's commonly associated with H. pylori?
So first of all, realize that H. pylori, even in 2022, is one of the most common human infections. It's been estimated that over half of the world's population harbors infection with H. pylori. So this is still an incredibly common thing. Now, realize that the prevalence, or how commonly you find H. pylori, varies a lot from country to country. So the prevalence in the United States is much lower than in developing countries where there's poor sanitation, because H. pylori is primarily thought to spread through a fecal oral pattern of transmission. So contaminated water, unclean food, poor sanitation, all those things have been associated with a greater likelihood of spreading H. pylori infection. And fortunately, for the most part, those are things that we don't contend with in the United States or other developed countries. Um, I touched a moment ago on the diseases for which H. pylori has been associated. And first and foremost is almost everybody that gets H. pylori will get an intense inflammation in the stomach that we call gastritis. A smaller percentage will go on to develop peptic ulcer disease. That is, those breaks in the lining of the stomach or first part of the small intestine related to that intense inflammation and injury. And then an even smaller percentage will go on to develop gastric cancer. So that is cancer of the stomach. And that can take a couple of different types of or forms. A certain type of lymphoma called malt lymphoma, as well as gastric adenocarcinoma. So H. pylori is really important for all those things. And there are a couple of obscure things that people should be aware of. Listeners should be aware that unexplained iron deficiency anemia has been associated with H. pylori infection, as well as a condition where the platelet count is unexplainably low, something called idiopathic thrombocytopenic purpura, or ITP, has also been associated with H. pylori infection. So the suite of indications is still relatively small, but extends beyond just gastritis, peptic ulcer disease, and stomach cancer.
Yes. Thank you so much for touching on some of those important things that I think it's very crucial for some of our listeners to really hear from you today. Just to kind of shift the topic here just a little bit away from H. pylori, but just on another condition that's also part of the bacteria in the GI tract. Dr. Brenner, during your presentation, you spoke a lot about small intestinal bacterial overgrowth, also known as SIBO. How similar is the manifestation of IBS and SIBO?
Yeah, so that's a great question. And SIBO is another field, like Dr. Chey just mentioned, where people have kind of come along kicking and screaming as well. They don't want to believe that it exists. There are some fallacies in the testing, which I'm sure we'll touch on a bit later, but this is something that's very real. And one of the questions that I always ask myself when I find somebody or I diagnose somebody with SIBO who already has a diagnosis of IBS or meets criteria of IBS is this IBS? Is this SIBO? Or is this semantic? Meaning, are we just talking about different terms presenting with the same symptoms? Because the symptom profiles are very similar. The most common symptoms of SIBO include abdominal pain, bloating, distension, nausea, alterations in bowel habits, more so diarrhea with the actual SIBO, which remember is an overgrowth of colonic bacteria in the small intestine, as opposed to a newer set or terminology, nomenclature known as IMO, or intestinal methanogenic overgrowth, which has been associated with delayed motility and linked to chronic constipation and irritable bowel syndrome with constipation. The difference here is that with IMO, we're talking about single-celled organisms, or archaea. They're not even bacteria, and they don't have to be in the small intestine. And that's where there's been a change in the way that we define these two. But the symptoms overlap because our definition of irritable bowel syndrome is abdominal pain associated with alterations in stool frequency or stool texture. Now, if you look at the literature, there have been multiple different systematic reviews, meta-analyses that have shown over and over again that people with irritable bowel syndrome seem to have a higher likelihood of a positive breath test, if that's what you use, or quantitative cultures showing that there's evidence of SIBO. And no matter how you cut or slice the data, whether you're looking at older criteria, newer criteria, it looks like the prevalence is about 30%. So it looks like if you take a population of individuals with irritable bowel syndrome and you test them, about 30% of them will have evidence of small intestinal bacterial overgrowth. So it is a good percentage of patients with IBS, but it's not everybody.
Yeah, yeah. And so you're talking a little bit here about the testing. When would you consider testing someone for SIBO, or I believe you referred to it as IMO?
Yes, intestinal methanogenic overgrowth. This is a hard question to answer, and everybody has their own philosophy on this. And I'll be honest, I spent a lot of time thinking about this, and I don't know that I necessarily have a specific answer. I don't know that I have a direct algorithm. I think on the emo side, which is more linked to constipation, irritable bowel syndrome with constipation, it's a little bit easier for me. We usually see patients who are refractory to over-the-counter therapeutics, and the argument at this point is we should be considering or concerned for the potential for what we call functional defecation disorders or pelvic floor dysfunction. And a lot of patients will present with constipation and associated abdominal symptoms, bloating, pressure, discomfort. And a lot of times, if a patient has pelvic floor dysfunction and we treat it, those symptoms go away. On the other side of the spectrum are patients who present with these abdominal symptoms along with their constipation, and they've received the over-the-counter medications. And the problem with a lot of the over-the-counter medications is that they only treat bowel symptoms, frequency, texture, straining, sensations of incomplete evacuation, but they're not effective for abdominal symptoms, and in some cases can even worsen the abdominal symptoms. So the argument there is we now have good evidence-based therapeutics like secretagogues and prokinetic agents, things like linaclotide, lubiprostone, plecanatide, tegaserod, that can improve both sets of symptoms. So I think a lot of practitioners will either try to treat the pelvic floor dysfunction with pelvic floor physical therapy and biofeedback or some of these newer therapeutics. And then when there's the abdominal pain or discomfort that persists, think about other potential causes. And that's at that stage in the algorithm that I start thinking about breath testing for emo. On the SIBO side, it's a little bit harder for me. I think a lot of times I end up doing it realistically because patients are educated. They go online, they learn about this. People are looking outside of the allopathic world for interventions. They see a lot of naturopaths, and I would argue that a lot of my naturopathic colleagues, even at Northwestern, will run these breath tests as a first-line intervention. And so in some cases, it's a matter of just doing what the patient wants. If the patient's primary complaints are bloating discomfort, there are no associated bowel symptoms, then a lot of times I'll move specifically to targeted testing for celiac, looking for overgrowth of hydrogen, methane, and now potentially hydrogen sulfide, which has been linked to the development of diarrhea. But I also talk to my patients about the pitfalls of doing these tests. We have two major tests when it comes to breath tests. The lactulose breath test, which is probably the more sensitive test, but we also know that lactulose isn't digested or absorbed. So it gets into the small intestine. It can increase what we call mouth to colon transit. And so you can see more false positive studies. Glucose, which is the study I use more frequently, is specific or more specific than lactulose, but it's absorbed very early in the GI tract. So if somebody has more distal small intestinal bacterial overgrowth, you may miss it. We have problems with the patient, the way some people perform these studies. People use various amounts of glucose or lactulose. The interpretations are different, although we've tried to standardize that with the North American consensus and the American College of Gastroenterology guidelines on diagnosing and treating SIBO. But still, there's a lot of variability out there in the way that the test is performed. And then there is the percentage of individuals who are completely healthy and will have a positive test. And we see this in everything we do. If you look at the numbers in the literature, anywhere between about 10 to 16% of healthy individuals, if you perform a breath test, will have a positive study. And so that means 1 out of every 6 to 10 people we test, they'll be positive. So we have to be aware of that. And then it comes to the treatment issue. You're going to have patients who you treat, you give them the medication, the symptoms go away, but you retest and the bacterial overgrowth is still there. So you may have treated SIBO, but it's unlikely to be the underlying cause of the symptoms. Then there's the flip side. You treat these patients, they don't get better, the test is still positive. Where do you go from there? So I'm not saying that, we shouldn't be doing these studies. I'm saying there's still a little bit of variability. I'm not quite sure exactly what to do for the test in all patients, but we have to understand the benefits and the pitfalls of both treatments and diagnostics. And this is a real fertile area for research. There's a lot more that needs to be done here. So I always tell my patients, we're kind of at the base of the iceberg when it comes to understanding this process, more to come.
Yeah, and even though it's not as commonly known in the general public, it's also still an unfamiliar territory for the researchers as well. So definitely opportunity there to figure out what's going on. And Tina, I see that you're nodding your head here while Dr. Brenner is talking about some of these things. So can you share just a little bit about your patient journey so far and kind of what it looks like from your perspective as someone living with small intestinal bacterial overgrowth?
Absolutely. So that's a great question, Hayley. I think, I totally agree with what Dr. Brenner was saying from a clinician's point of view. From a patient's point of view, I have been living with SIBO and potentially SIFO as well, the small intestinal fungal overgrowth, since 2015. I received a series of breath tests, lactulose breath tests, and they were not super conclusive. We had to do them 3 times, which was very difficult to go through each time. I'm also vegetarian, and that made it very difficult to prep for this. Like basically all I could eat was like rice and tofu the days before for this. And so that was very challenging. And they were like, we don't want to keep putting you through this, but we're just seeing lactulose is creating a reaction in you. It looks like you might be positive for SIBO. And this was after I'd come back from surgery. I've had multiple operations around having inflammatory bowel disease that had altered my intestines. And I was suffering from constipation, some pain above my navel, and the constipation just felt pretty severe at times. And my stool was also starting to smell kind of rotten. And I hate to share this piece, but I feel like that's a classic sign for us patients to know that there's something wrong. When it smells like rotten eggs is when I was like, you know what, doc, this is happening to me. What do you think is going on? And that's when they were like, we think you're SIBO positive, even though your tests are not coming back conclusive. I did not respond that well to medications like the traditional antibiotics like rifaximin. So the dietitian in my IBD center was luckily familiar with SIBO, and she put me on courses of Candibactin AR/BR, which are more of the herbal sort of away from the allopathic treatments. We worked on diet. I've done a number of diets over the years where we have tried things like soups and smoothies to ease the constipation, but also we have tried like higher fiber diets in the beginning, tailored that. to see if the constipation would be relieved, because I kept being told that SIBO is more of a secondary disorder than a primary one. And if we would resolve my constipation, perhaps the SIBO would come under control. Things started to get worse over the years. My constipation went from bad to severe. So in 2015, when I came back from surgery at Mayo Clinic, things were bad, but they were not severe. And also I was remitting in terms of the Crohn's disease. So and my fistulas had closed, and I was just trying to enjoy my newfound life to really be like, you know what, I need to deal with the SIBO stuff. But things started to get worse, I would say, in 2017, 18. I had an obstruction the summer of 2018. And that's when I realized, all right, Tina, you really need to get help for this. So at that point, I had some testing redone again in New York. I had contacted my Mayo Clinic physician as well, and he's like, I think there is something underlying going on that we need to figure out. Now, he actually found, when I went to the Mayo Clinic, gastroparesis, antral, in the antral stomach. And he's like, this could be the cause of some of your issues. So it was like this multi-staged process of trying to determine what might be causing my problems. So the gastroparesis was definitely contributing to some of the slowdown, but I was still complaining of, hey, there's something like lower down in my intestines going on. And that's when they started to explore me for chronic intestinal pseudo-obstruction. In 2019, they started to look at, hey, is this a surgical mechanical problem that might be causing your SIBO? Because at this point, I was needing to be on something chronically to control the SIBO symptoms. So my symptoms, like Dr. Brenner was talking about, were very similar. This bloating, this pain above my navel, this gurgling, the rotten egg smell that I told you about. Also this bizarre sort of weight gain that came with the bloating as well. And I didn't feel like I could eat well either. I had cut out a lot of grains, and this goes into, restricted or disordered eating. I had started to cut out a lot of grains, even though I was talking to my dietitian about how to go about these things. I started to become afraid of food. And that became a very big reality. Like, for me to even have a few bites of pasta became scary, because I was like, oh my God, this is going to set things off. And I would say in 2021, March, I actually went to see a SIBO specialist. And what she did was she went in through an upper endoscopy, and she did a jejunal aspiration. And she said that this could be, this could have sort of false positives too if things get infected. She's like, we have to draw a very clean specimen from your upper endoscopy. And so she did the absolute best she could. She found gram-positive rods, she found candida, and she's like, you have both SIBO and SIFO. I'm going to treat the SIBO first. We're going to try rifaximin again, since it's been a bunch of years. First couple of days, I felt a lot better, and then it came back with a vengeance. So she's like, you're failing this. We really need to figure out what's going on with you, because motility-wise, you've been on so many medications, some of the medications that Dr. Brenner mentioned, linaclotide, with an ostomy without a colon, it was causing explosions. Even my ostomy would leak overnight. I've been on plecanatide, lactulose as a motility agent to go to the bathroom as a laxative. I've also been on pyridostigmine, which gave me a lot of twitching. So I've been on a whole slew of medications, and on top of that, prucalopride. So all of these medications meant that my IBD had to also be consistently monitored to make sure that there wouldn't be any sort of perforations of the bowel either, that my IBD was staying in remission, because there were concerns about that, taking so many prokinetic agents and so many laxatives too without a colon. It got to a point where we were just like, how do we get to the bottom of this? Because if this was a true motility issue, we would have figured this out. My small bowel follow-throughs would have come back showing slow motility. Nothing was showing slow motility. I was a mystery for years. I go to Pittsburgh to speak at a conference for IBD, have a small bowel obstruction. I've been having them even on these meds, believe it or not. And they took some CT images, small bowel transplant, sat down with them, and they said, we see a few sites of obstruction. We need to clean them out. You have a hernia strangulating your small bowel. And I was like, oh my God, I needed surgical intervention to open these things up, to fix them, to fix the obstructions. And since then, it's been eight weeks post-op now. I don't know if I have SIBO anymore. I'm kind of in flux right now, still recovering from surgery, but I haven't had quite the symptoms that I used to have, and things move on their own. I'm not taking the prokinetic agents or the laxatives anymore, other than what's used to manage my gastroparesis, which does cause some slowdown still. But overall, things are moving better. I still need to probably have some kind of testing to check for SIBO, since I've consistently had it for 5 or 6 years. But overall, things are moving better. So I guess the moral of my story is, I understand that SIBO is a secondary condition, but it is quite debilitating of its own right, requires quite a bit of medical management. And in a case like mine, where surgery could have like a mechanical obstruction could have been causing it, a lot of different things have to be explored, especially in complex patients, to understand, is this truly a motility problem or is this a surgical problem? So that was my experience with SIBO.
Yeah, and so, Tina, such resilience in your story, and just hearing you talk about how much you advocated for yourself really in this healthcare system, and how difficult that can be sometimes to really stand up for yourself and realize that you need more care, because whatever you have going on and whatever treatment options you're currently on, it doesn't seem to be helping. So really just one thing that I feel like was a really good takeaway here is just the tenacity and just being an advocate for yourself always. And either Dr. Chey or Dr. Brenner, how common is this type of overlap in the conditions with patients living with SIBO?
It's more the exception or more the rule than the exception, to be frank. I think there are so many different things to take away from Tina's story. Just a couple things that come to mind that I think are important for people in the audience to realize. It is not usual to have chronic bacterial overgrowth like that. If you're to a point where you're having to take antibiotics or herbals all the time to control your SIBO, there's one of two things going on. One is you have pseudo-obstruction, so the intestine isn't working and things cannot be cleared, and thus you develop chronic bacterial overgrowth, or there's a mechanical obstruction. Okay, so and the mechanical obstruction can be like Tina described, related to previous surgery, but it can also be due to other things, like for example, small bowel diverticulosis. And so it's really important for people not to attribute everything to IBS in a situation where things are not behaving like they normally do, i.e., you need chronic antibiotics, you need chronic herbal therapies. It's really important to do the evaluation to understand why that's the case, because that is not usual. That is not the usual scenario that we see in an IBS patient, for example. I'm really glad that Tina had providers that were able to have enough insight to figure that out. But unfortunately, I'm sure there are people in the audience that have had different experiences, and it is really important to understand when you need to advocate for yourself, and that's a time for sure when you need to.
Absolutely.
And that's key. I mean, understanding the underlying physiologic processes that lead to the potential of developing small intestinal bacterial overgrowth. I mean, when I heard Tina's story and I saw her video, it's something I thought about immediately when she mentioned all of her surgeries. I mean, if the ileocecal valve, which that little break that separates the small intestine from the colon, is eliminated surgically, you have potentially trillions of different organisms in your large intestine, which now have a bridge to your small intestine. So that explains it. As you just mentioned, Tina, the strictures. The strictures allow for these bacteria to harbor. So you have these potential causes, and when you hear this type of symptom profile and you've given the standard treatments and people aren't getting better, you want to start thinking about A, Could this be another process causing the symptoms, i.e., is it SIBO and not the Crohn's, or as Bill just mentioned, irritable bowel syndrome? And B, if there is this disorder and I treat the disorder, then what can I do to keep it from coming back again? And it sounds like, Tina, in your case, that was surgery, release of the mechanical strictures, and that's proved beneficial for her. So it's not just about treating the disorder, it's figuring out the underlying cause and seeing if you can mediate that cause. Now, in some cases, you may not be able to. One of the other things that Tina mentioned was the chronic intestinal pseudo-obstruction and the use of pyridostigmine. That's to keep things moving down the GI tract. So if somebody has pseudo-obstruction with a neuropathic, myopathic disorder like scleroderma or Parkinson's, you're really unlikely to fix those issues. So you want to think about another way to get around them.
You know, one practical thing that's worth mentioning too, without being critical of your doctors at all, Tina. I don't mean to be, but it's probably just for people in the audience. It's if you're suffering with a condition and you've had a colectomy, it's probably not a good idea to use linaclotide or plecanatide in a person that doesn't have a colon, because you're pretty much 100% going to get diarrhea. Because the reason why people don't get diarrhea on those drugs is because of your colon. Your colon actually reabsorbs a lot of the fluid that the drug causes to be released in the small intestine. So just a practical tip is, if you have a colectomy, probably a GCC agonist like linaclotide or plecanatide is probably not a great option, because 100% you're going to get diarrhea.
Oh, I would absolutely agree with that, Dr. Chey. I think I was so desperate to stop having obstructions, and my doctor was like, we can't find the source of obstructions. So for us, it was like, do we manage this and try to get things moving, and it was we went back and forth between plecanatide and linaclotide, and I was like, doc, I can't do this anymore. It's just too much. So I completely agree with that statement. I think that as patients, we have to advocate and say, I can't do this. You know, if we have to use something else like a pyridostigmine or a lactulose that didn't do quite what linaclotide or plecanatide do to patients without a colon, then that's what you do.
One other point to the patients out there, please realize that, and in Tina's case, it took a while to get there, that there were mechanical obstructions. These drugs are actually contraindicated in the setting of a mechanical obstruction. So you don't want to use these in those scenarios. So I'm glad that they found what the underlying cause was and shifted to some other practices as well.
Exactly. And that's a really good point, Dr. Brenner. It was dangerous, and I got to the point where there were concerns around bowel perforations. And that's why I wanted to mention that was a huge concern too. So I'm really thankful and grateful that my doctors finally found the source of these obstructions so that I could live a better life and not be SIBO ridden all the time, because it really was taking a toll. But you know, I think what's important to understand as a patient is that we go through a lot of trial and error. And oftentimes we can get very exhausted, but our doctors are with us through this journey. And I was very closely managed, and honestly having a lot of testing done to figure out what was causing all this, because they did not want to be using these medications on a patient like me. So it was a very challenging case, I think, for them. And I'm just very thankful to be on the other side and in recovery now. But this can be quite a complex, long process to figure out what could be causing some of these issues in patients like myself.
Yeah, absolutely a team effort, and everyone having to kind of put their heads together to figure out how to help a patient with such a conditions similar to yours, Tina. In your story, you mentioned that you were diagnosed with SIFO, which was small intestinal fungal overgrowth. Dr. Brenner, do you want to touch on that, or either Dr. Chey, one of you two could mention what that might be?
Yeah, this is a newer science, and it falls on the spectrum of SIBO. So replace the B with an F, take out bacteria and make it fungi. And again, it's just overgrowth of these organisms in the small intestine. There have been some studies looking at the most common organisms associated with SIFO, and they come from the Candida species. Candida albicans, Candida glabrata are the most frequently identified organisms seen. Now, as far as I'm aware, maybe Bill knows differently, but as far as I'm aware, there's not currently a breath test to assess for SIFO. It has to be done by quantitative culture in that sterile manner that Tina was mentioning earlier. And we really don't have validated thresholds for what's considered an abnormal study. I think right now we consider the same that we do for SIBO, 10 to the third colony forming units per cc. But that comes from one of our colleagues who's an expert in this field, Satish Rao's lab. He's kind of made that the threshold that I think a lot of people are using. It's hard to get diagnosed with because most clinical centers are not performing this study. It's difficult to do. There can be easy contamination with oral pharyngeal fungi. And we don't know what to do with treatment. You know, Tina mentioned that she tried rifaximin and people cycle antibiotics. We don't know if that's the safest process. And with these, using things like azoles, fluconazole, itraconazole, voriconazole, or nystatin, having to use these things over and over again, we don't know what the long-term outcomes and consequences are here as well. So again, just a real fertile area for research. My colleagues who are treating this, they're doing it empirically. If you failed everything else and they think there could be fungi in the small intestine, they're giving a course of antibiotics and seeing if people respond. But I want the audience to realize that, again, there is a high percentage of placebo response in this realm and in the what we call disorders of gut-brain interaction space. So we want to be very confident in what we're doing and making sure we're not getting a placebo response when we're treating individuals, especially with these antifungals.
You know, I'll tell you one small story about SIFO too, which is I think will be interesting to your listeners, and that's the story of something called auto intoxication syndrome or auto brewery syndrome. There's actually another paper that just got published on this literally within the last few weeks. I was just reading it and to refresh my memory, but it's actually a condition where people develop SIFO, and basically they're oftentimes infected with brewer's yeast, so Saccharomyces cerevisiae. So when you eat carbohydrates and they interact with that particular fungi, it produces alcohol. So there are patients that will say that after they eat particularly a carbohydrate-rich meal, they'll feel drunk. And in fact, there are cases documented where people have actually been arrested for DUI related to being intoxicated when they never drank any alcohol. And this is completely curable with treatment of the fungal overgrowth. Now, this is a really rare condition, but it is proof of concept that this fungal overgrowth does exist. So just something to be aware of in case anybody is suffering from that symptoms where they feel like they're feeling intoxicated after they eat a meal.
Yes, absolutely. Thank you for bringing that into the discussion and just some touching on some background so that all of our listeners can understand all of the conditions. And before we kind of wrap things up, I really want to give each one of you guys a chance to kind of touch on anything, make any comments that you might want to touch on based on your presentation, as well as any kind of encouragement that you might have. So Dr. Chey, I want to start with you because I know we kind of drifted a little bit off of H. pylori, but if there's anything that you might want to mention before we kind of wrap the discussion up, please do so.
Yeah, so I think the important thing to realize is that H. pylori still remains an important problem in this day and age. Now, the good news is that, again, in the United States, the prevalence is lower than in many other parts of the world. But for people that have immigrated from other parts of the world or who have a family history of ulcer disease and they're having GI complaints, H. pylori should definitely be considered. And I think the exciting thing that I didn't have time to talk about in the lecture is that there are now going to be stool-based tests that will allow us to determine whether a strain of H. pylori is resistant or sensitive to specific antibiotics. So once that becomes widely accessible in the United States, it's going to be a game changer. It's going to move us from that empiric strategy where we talked about earlier, where you have symptoms, you have the infection, so we just sort of make our best guess by choosing some antibiotics, to knowing which antibiotics are going to work for a specific individual. So that's exciting. There are also a number of new treatment regimens which have become available or are going to become available soon in the near future. So the whole waterfront of making a diagnosis and treating H. pylori is undergoing some radical changes right now. And the good news for people in the audience is radical changes for the better.
Mm, mm. Thank you so much, Dr. Chey. Tina, do you want to provide any comments or any words of encouragement for the patient community out there?
Absolutely. I think when it comes to a diagnosis like SIBO, I've talked to a lot of patients. Many of us are frustrated because we don't know what's happening with our bodies, and no matter how clean we might eat, it's never enough. And we want to blame ourselves for this, but this is not our fault. I want to always say that with digestive conditions. SIBO is not our fault. It is usually related to some other condition, as we've talked about, and it behooves us to look into that and to have the tenacity to really advocate for ourselves. I know it's exhausting. I know it's very tiring to do so. I myself have been there, but there is another side to things, and that you can recover from this. Sometimes we just have to keep pushing, keep being proactive, and not settle for less. And that's how I've done this. That's how I've come out on the other side. And I encourage you to pursue that avenue, even if you need to get a second opinion, and go to somebody who believes in SIBO, believes your symptoms, can understand what you're going through. With me, what was very challenging is because I didn't have a colon or rectum. In the beginning, many people didn't want to believe that I could be having constipation or that I could be having obstructions in quite that way, where things were so slow and then just stopping. So I think it's very important to find somebody to hear you, to listen to you, and to keep moving forward and do that discovery process with you to find out what's wrong. Sometimes it can take years, but hey, it's going to be worth it at the end of the day.
Yes, thank you so much, Tina, for being a very active patient advocate in the community. You using your voice encourages others to use theirs. And so I just want to say thank you on behalf of IFFGD. Dr. Brenner, last but not least.
Sure. I think when it comes to SIBO, more so than SIFO, this is what I call commonly uncommon disorder with very non-specific symptoms. So it can be hard to identify, and I think that the evaluation comes later in the workup. We still have a long way to go with respects to knowing who we should be trying to test, what tests we should be using, and how to treat it. As I mentioned in my lecture, if you Google treatments of SIBO, you will now get more than 7 million hits. So do your homework. Do your homework and look for somebody who understands the evidence behind treating this disorder, whether it be allopathic or naturopathic. But another message I want people to understand is this. Don't look at SIBO with blinders on. I've had patients who come in, they have been all over the world because they've tried everything to try and treat this. They've had positive studies, treated it, and had no evidence of it subsequent, and it's still believed to be this disorder. There's overlaps between this and other illnesses, and the key is teasing out which of these are actually causing your overall symptom profile.
Yes, thank you so much to each of you for just joining us today and providing us with your time. Obviously, we know that you guys are very busy, so we really appreciate you taking the time to answer some of the questions that many of our viewers have had. And I just want to say thank you to everyone who is watching. And if you would like to view any of the other presentations or maybe the presentations from our speakers today, visit our IFFGD YouTube channel where you can like and subscribe and get any updates, especially those from the NES 30th Anniversary Edition program. So if you guys have any questions, please contact our staff at IFFGD at iffgd.org. Again, thank you to everyone who's watching, and thank you so much to our presenters today.